Sir, we are live now, sir. Please start. Sir, please start.
Good evening. Welcome to the 5th edition of the GIS program. Now, before we go on to the program, I would like to have a brief introduction of what this GIS program is. Now, this GIS has been a program which is a program for, it's a gastrointestinal surgical training program. This is a program which was envisioned by the leaders of Sun Pharma, who had taken a big survey of surgeons practicing in the periphery, especially the 3-tier cities and the periphery, to see what their need is in clinical practice. And because of their inaccessibility to reach to surgeons in tertiary care centers, or because they do not have contact with leading surgeons across the country to sort out some of the issues they have in day-to-day practice, they wanted to interact with senior surgeons across the country on various issues which can be practiced at a peripheral level. So Sun Pharma did an extensive research, survey of all these surgeons, and the people who are behind is Mr. Joseph Gerald, Vamshi, Abhijit. All these people have tirelessly worked on this. And they finally requested us to do some technical videos which should help them to improve what they have been doing in current day clinical practice. So in the last 4 or 5 sessions of this program that we have had senior surgeons who have been taking up some issues of basic surgical procedures, be it be open or laparoscopic, share some technical tips so that these surgeons who are at the periphery can improve their technique, and also they'll be able to get in contact with these senior surgeons across the country to sort out some of these issues they have in day-to-day clinical practice, because they don't have access and they don't have support systems like what we have in tertiary care centers. So we have not had excellent topics initially, and we have had good response. And the future was, we not only wanted to have some talks, we also wanted to have live transmissions. So we experimented with this process of live surgeries during this program. And the last program was a big success. Actually, we had a lot of people who logged in to see these live procedures. So we decided that the GIS program that is going to be, and it is going to run on a long term, will have both talks and also live surgeries from various institutions across the country, and also from maybe some centers across the world. So this session, actually, this is one of the commonest indications, actually one of the commonest problems that we face in clinical practice is gastroesophageal reflux disease. Obviously, many of these patients do well with medical line of management, and they keep popping in pills, but we know that there is a significant percentage of people who do with a one-time solution, a surgical solution, and that to a minimally invasive solution, which can tackle this problem, and then they will have a comfortable life. But there seems to be less awareness and also less expertise among surgeons practicing at periphery. Some of them are doing extremely well, but some of these surgeons, we've taken a survey, they wanted to know some technical tips as to how they can refine their procedures. So for this session, we have a very senior surgeon, a close friend of mine, Dr. Sanjeev Haripakthi, minimally invasive surgeon, true surgeon, very humble to the core, extensive publications, lot of good work, lot of publications, good academic presentations across the globe, and he's been doing yeoman service in the field of gastroenterology. Now, he happens to be the director of the Kaizen Hospital and the minimally invasive surgeon. So I requested Sanjeev, if it's possible for him to share some technical tips of doing a laparoscopic fundoplication on behalf of entire Sun Pharma and behalf of myself, Sanjeev. Thank you so much for spending this time to share your views with the surgeons across India, and I'm sure surgeons will benefit. And the screen space, the air time is yours now. Thank you so much for accepting to be faculty on the GIS program.
Thank you very much, Dr. GV, for these wonderful words, and I thank you for inviting me to this forum. which is, it's a wonderful initiative, and I really admire the spirit behind this initiative to reaching the secondary and the secondary centers in the Group B and Group C cities. I think this is a wonderful initiative, and I'm sure it will go a long way in helping and handholding these surgeons to, practice these procedures. I'll start and come to the topic now. The topic given to me is fundoplication, and I feel that fundoplication is a very good procedure, and it is a very rewarding surgery. But before going on to the technical tips, I think there are certain important issues regarding the selection of patients. Those are very important, and that's why I'll start with a presentation and then I'll go to the video. So fundoplication as an operative procedure has come a long way since it started more than 20 years ago, and it has now become the gold standard procedure, one-time procedure for hiatal hernia, and it gives excellent results in about 90% of patients, but there would be about 5 or 10% of patients who will have some kind of issues, some kind of problems. And that's why it is very important to understand the physiology, pathophysiology of GERD, to understand the decision-making behind what goes behind fundoplication, and what kind of procedure we should do, what kind of wrap, what kind of technique we should employ, what are the technical tips. So before I go to the video, I'll come to the to the presentation. So GERD is a very common problem these days. It's a lifestyle disorder. It is increasing in its frequency, and basically there is a very commonly something called physiological GERD, which is like occasional symptoms, burping, occasional reflux, occasional heartburn, but this is not significant, or this is not pathological GERD. What is pathological GERD are troublesome symptoms, mild symptoms which occur at least 2 times a week, or moderate to severe symptoms at least once a week, and which adversely affects the quality of life of the person. So this is called a pathological GERD, or a significant or a clinical GERD. The clinical symptoms of GERD can be divided into typical, atypical, and extraesophageal symptoms. And mind you, surgery is going to only benefit the typical GERD patients. Surgery will not benefit the atypical GERD patients or some of the extraesophageal patients. Extraesophageal also, some patients which are related to GERD will definitely benefit, but we have to understand.
Sorry to interrupt you, sir.
Yes, please.
Sir, your slides are not visible, sir.
Not visible?
No, sir. Please share it again, sir.
I'll stop sharing and share it again. Just a moment.
Yes, sir. Yes, sir.
Is it visible now?
Now
Yes.
it's visible, sir.
Okay.
It started with, yes, sir.
Okay. So that was the first slide, the troublesome symptoms and the pathological GERD. So the typical symptoms are the only symptoms which are going to benefit from a laparoscopic fundoplication. And this is very important at the outset. When we see the patient for the first time in the OPD, in the clinic, we should mention whether these patients have typical symptoms or atypical symptoms, because that will help us in the future to take a decision whether these patients will benefit from a fundoplication or not. So typical symptoms, there are only 2 typical symptoms of GERD. One is heartburn and second is regurgitation. So these are the only 2 typical symptoms of GERD. Rest, most of the other symptoms, even dysphagia is not a typical symptom, though it is mentioned here. It is not a typical symptom. Chest pain is also not a typical symptom of GERD. So please remember, there are only 2 typical symptoms of GERD, heartburn and regurgitation, and this will benefit from a fundoplication. Dysphagia can be because of several diseases. We have to rule out achalasia cardia. We have to rule out other esophageal motility disorders. We have to rule out other causes of dysphagia like malignancy, corrosive, other strictures. All these have to be ruled out. And chest pain could be cardiac, could be non-cardiac, it could be esophageal motility disorder. It could be any reason causing the chest pain. So these are not classical symptoms of GERD. Atypical symptoms. are dyspepsia, non-ulcer dyspepsia, epigastric pain, which could be because of several reasons, bloating, nausea, belching. All these also are considered atypical symptoms of GERD and which may not be relieved by fundoplication. Extraesophageal symptoms are the upper respiratory tract, upper esophageal tract symptoms like chronic cough, asthma, dry throat, laryngitis, change of voice, sometimes even sinusitis. Sometimes patients also have headaches because of recurrent sinusitis related to GERD. So these are some of the extraesophageal manifestations which may respond to GERD if they are definitely related to GERD, which may not respond to fundoplication if they are not related to GERD. And that's why evaluation by an ENT surgeon is necessary if we are going to operate for these extraesophageal symptoms. This is the Montreal classification of GERD, which describes the GERD into esophageal syndromes, extraesophageal syndromes, typical reflux syndrome, and esophageal injury, which is also called erosive GERD. So at the outset, when we see the patients in the clinic, we should also try to find out whether this is an erosive GERD or a regurgitant GERD, because this also responds differently to medications and to surgery. Erosive GERD definitely responds well to medical treatment, PPIs, but regurgitant GERD sometimes does not respond well to PPIs or with medical management, and they respond well to surgical management because it's a volume reflux, it's a mechanical problem, whereas acid reflux and erosive symptoms like reflux esophagitis, strictures, Barrett's, they are the ones which are called erosive GERD. Extraesophageal syndromes we have already discussed. It could be lung, it could be upper respiratory infections, anything. Now, PPIs are the backbone of treatment for GERD, and PPIs are used extensively now. Even double dose PPI is commonly used for GERD. It works very well in erosive GERD to take care of the symptoms, to take care of the disease, the esophagitis, the ulcers, healing of these ulcers. It is very good. There is no doubt about it. And long-term use also is nowadays used for most patients by physicians. But one have to be careful when we are using PPIs for a long period of time, especially continuously. Prolonged and continuous acid suppression can cause several adverse effects. These are all well known, well described in literature, and this can be related to acid inhibition or unrelated to acid inhibition. The common ones that we see which are related to acid inhibition, especially in ICUs, are increased risk of pneumonias. For patients, there is increased risk of GI infections because acid is an important barrier for GI tract and an important barrier against infection. Gastric, fundic gland polyps, fundal mucosal hypertrophy, and sometimes even carcinoid tumors. We have seen number of patients who have had prolonged acid suppression and have developed small multiple polyps, neuroendocrine tumors of the stomach. Changes in gut microbiome leading to small intestinal bacterial overgrowth, SIBO, and deficiencies of several important elements like iron, B12, calcium, magnesium, folic acid. All these can happen. Increased risk of gastric colon cancers has been described, and risk of spontaneous bacterial peritonitis and hepatic encephalopathy in cirrhotic patients. And many drug interactions with cardiac drugs, clopidogrel and other, has been shown conclusively proved. And that's why we have to be careful when we use long-term acid inhibition. We must tell our patients about the risks involved, and we should take care of these risks also. So this also will become an important consideration when we are going to choose a fundoplication versus long-term PPI usage. Now let us come to the indications of surgery, and this is very important because when do we operate? What are the patients in whom we will operate? It's a very important decision. Patients who have esophageal or extraesophageal GERD symptoms that are responsive but not completely eliminated by PPIs are the primary patients who need surgery. Patients who have no response to PPI, one should think 5 times before operating them because they may not respond to surgery also, except if they have a regurgitant GERD, then they will not respond to PPI, but they will respond to surgery. But if they have erosive GERD, they must respond to PPI, then they will respond well to surgery. So whether they are responsive to PPI or not should also be mentioned in our charts, in our notes, clinical notes or OPD notes. We should mention, number one, whether these patients have typical symptoms or atypical symptoms. Number two, whether they have esophageal syndrome or extraesophageal syndrome. Number three, whether they have responsive GERD or unresponsive GERD. Number four, whether they have erosive GERD or they have a regurgitant GERD. And number five, whether they have uncomplicated GERD or they have complicated GERD because of complications. So these are the 5 things that we should mention, and all these 5 things can be documented clinically. You don't need many sophisticated investigations. Basic investigations like endoscopy will be needed, but that is available now everywhere, and it will not be a problem to identify these patients. The second are the patients who have heartburn, which is eliminated by PPI, but continue to have regurgitation, volume reflux, and symptoms. So these are the patients who will definitely benefit from fundoplication. Patients with well-documented reflux events preceding symptoms such as chest pain, coughing, or wheezing. These are also patients who have atypical symptoms, who have extraesophageal syndrome, but they have classical correlation with GERD symptoms. So these are the patients who will respond well to surgery. Patients with GERD who have complications, which is also called complicated GERD, like stricture, Barrett's esophagus, vocal cord injuries, or those who need continuous double dose PPIs are the patients in whom surgery should be considered. Patients with well-documented GERD who desire to stop PPI usage despite excellent control because of either side effects, because of lifestyle, or for any other reason, then they are the patients in whom we can consider for a fundoplication. But we should also remember which are the predictors for bad outcome so that we avoid surgery in these patients. And this would be some relative contraindications to fundoplication. So we have to be very careful when we operate in these patients, especially young females who have psychosomatic illnesses, or they have some kind of a motility or psychosomatic disorders coming from lower socioeconomic status. So these are the patients in whom we have to be careful. When there are extraesophageal symptoms, a more of psychosomatic ailment, we must always constantly, whenever we are interacting with our patients, focus on their symptoms and try to identify whether these symptoms are more organic or likely to be functional. Patients in whom symptoms are likely to be psychosomatic, we should think 5 to 10 times before operating on these patients. Lack of response to acid suppression therapy. Patients who have no hiatus hernia, we should be very careful before operating these patients. And we should also know that the operation becomes more difficult in obese patients and in reoperations. Once a fundoplication has been done, a reoperative or a redo fundoplication is definitely a much more difficult operation. One of the important predictors today of bad outcome is obesity. And very commonly we see patients in our clinics who have both obesity and both have GERD. Now, whether we should operate on these patients, whether we should do fundoplication or we should do bariatric surgery, that is a question of debate, because if we do a fundoplication, they may not respond well. If we do a bariatric procedure like a sleeve, that can increase the reflux. And in the future, we cannot do a GERD or fundoplication because in sleeve, we have to remove the fundus of the stomach. So what to do in these patients? So primarily, we should see whether primary problem is morbid obesity or primary problem is GERD and hiatus hernia. If the primary problem is morbid obesity, their BMI is more than 35-40, then it is much better to do a bariatric procedure which will take care of the reflux also, and it will cure the patient not just from the weight loss but also from reflux. And the best procedure for this is the Roux-en-Y gastric bypass. It is done laparoscopically, and that will cure these patients from the perspective of reflux as well as help them for weight loss. If morbid obesity is not the primary problem and these patients have predominantly GERD, then we should think of doing a fundoplication in them, and we can do that. The second option is the morbid obesity is the primary problem, but GERD symptoms are very minimum and they don't have a hiatus hernia, then probably we can do a sleeve with hiatal repair rather than it is a crural repair or hiatal repair with a sleeve, or just a sleeve may be sufficient. Once they lose weight, their symptoms may come down. But if these patients have morbid obesity and hiatus hernia and severe reflux, please don't do a sleeve operation because they will get worse. They will have severe reflux. They will not be able to eat anything. They will have very severe reflux. And that's why it is better to avoid a sleeve in patients who have morbid obesity, hiatus hernia, and moderate to severe symptoms of reflux. Now, what about the evaluation? The investigations that are necessary. Upper GI endoscopy is the primary test which is done in all patients as a primary test, screening disorder, a screening test, and it will tell us whether these patients have hiatal hernia or not, whether they have any signs of reflux or not, whether they have, if they have GERD, whether they have erosions or not. Is it erosive GERD or a non-erosive GERD? And the second is, we will know the severity of the erosions, the severity of the esophagitis, presence or absence of Barrett's ulcer, presence or absence of complications like peptic stricture or polyps, and also some other diseases like H. pylori, ulcers, and others. So endoscopy is the primary screening test. Esophageal manometry is also a very important test. If we are planning for surgery, then manometry is essential, it is necessary. If we don't do manometry and do fundoplication, we may get away in about 80 or 90% of patients, but at least 1 or 2 out of 10 patients will have post-operative complications, problems related to fundoplication. And that's why it is better to do manometry for all patients before we subject them to fundoplication. We have published a paper on this where with 50 patients, we did a fundoplication many years ago without manometry. And then later 50 patients we operated after manometry, 100 patient series, which we had published about 10 years ago, and in which we showed that doing manometry is useful. In about 15% of patients, it will definitely be beneficial. Some optional studies that are necessary sometimes, but not always needed, are 24-hour pH monitoring, impedance testing, and upper GI studies like barium, meal, or a CT scan of the upper abdomen. So these may be necessary in selected patients, not in all patients. 24-hour pH monitoring is needed when patients have we don't know whether they have GERD-related symptoms or they are not GERD-related symptoms. And diagnosis is in doubt. There is no erosion, endoscopy is normal, then hiatus hernia is either very small, the symptoms are atypical. These are the patients in whom to decide whether the symptoms are because of GERD or not, we have to do 24-hour pH monitoring. Impedance monitoring also measures the volume reflux and the bile reflux apart from acid reflux. Upper GI series, barium or CT scan is needed to document hiatus hernia, to document shortening of the esophagus, to document a paraesophageal or a rolling type of a hernia, to document large hernias. So all these cases, we will need an upper GI contrast study. So endoscopy shows us the anatomy, shows us whether hiatus hernia diagnosis is done by measuring the Z line on endoscopy and the diaphragmatic pinch. If this distance is more than 2 centimeters, then these patients have a hiatus hernia. So when we go in, when we inflate, we should see, but it is important that we should also see when we are coming out, because sometimes when we are going in, we may not be able to see properly. So we should also look for erosions. We should also look for the classification of esophagitis. We should look for Barrett's ulcer. We should look for H. pylori, gastritis. We should take biopsies if there is any evidence. We should also do a proper retroflexion maneuver and see from below whether there is laxity of the hiatus or not, and whether there is a hiatus hernia, especially the rolling type or the mixed type of hiatus hernia, which is quite common. So So all these must be seen on a retroflexion. So, and while we are coming out also, it is very important to check again for hiatus hernia to measure the distance between the Z line and the diaphragmatic pinch after deflating the stomach properly. So that will, because there is a lot of variation between the findings of upper GI scopy. Even it matters whether you do an endoscopy with sedation or without sedation, and you should look for erosions. Presence and severity of complications also should be looked for, and other diseases should be looked for. So this is, you can see, this is a severe esophagitis. It is almost like a LA grade C, LA grade D, multiple areas of linear erosions and ulcers with a mild narrowing at the G junction. It suggests there is a severe GERD, and this shows a normal columnar line esophagus mucosa into the lower esophagus with islands of normal esophageal mucosa in between, which is called Barrett's esophagus. And this, we all know that Barrett's esophagus can be a pre-malignant condition. We need to take biopsies to document this and to make sure that there is no dysplasia, or if there is dysplasia, what is the degree? Is it mild, moderate, or severe dysplasia from Barrett's esophagus? Because this can lead to malignancy also. Stricture of the esophagus, narrowing because of repeated reflux, because of erosive ulcers, and because of fibrosis. This leads to stricturing of the lower esophagus and a peptic stricture, which can be dilated. And if it does not respond to repeated dilatations, then these patients will require a fundoplication. But when we do a fundoplication in stricture patients, we will do a preoperative dilatation, and we will prefer to do a tope or a partial wrap rather than doing a full fundoplication, because the risk of dysphagia may be higher if these patients develop a recurrent stricture of the lower esophagus. So this is the Los Angeles classification of endoscopy for esophagitis, and which will tell us the severity of the esophagitis. Grade A and grade B are considered to be mild esophagitis. Grade C and grade D is considered to be more severe types of esophagitis, and this will definitely require more aggressive medical management. So this is the Los Angeles classification. Grade A, less than 5 millimeters of mucosal breaks confined to each mucosal folds. Grade B is more than 5 millimeters mucosal breaks, and but confined to mucosal folds, not continuous between the two folds. Grade C is continuous between the two folds. There is esophagitis, and grade D is more than 75% of the esophageal circumference is involved. It is grade D of esophagitis. Esophageal manometry is a test which is a very useful test. It tells us two things. One, it will tell us the lower esophageal sphincter pressures. So it will tell us whether there is a LES pressure is high or is it low, is it hypotensive. In hiatus hernia, the LES sphincter pressures will be lower than normal. It will also tell us whether the esophageal body peristaltic activity is normal or abnormal. And the third thing it will tell us is whether hiatus hernia is present or not. So these are the three things that manometry will tell us. If the esophageal motility is normal, we also do manometry to select whether to do a Nissen or a tope fundoplication. And if the esophageal motility is completely normal, or it is upset, disturbed up to 50%, that is also considered as normal, then we do a Nissen or a 360-degree full wrap fundoplication. But if the esophageal motility is abnormal, more than 50% of peristalsis are disturbed, ineffective, fragmented, then we prefer to do what is called as a tope 270-degree posterior wrap or a fundoplication. So manometry also helps us to determine the presence of LES sphincters, esophageal body peristalsis, hiatus hernia, and to decide for what kind of fundoplication we need to do for these patients. So this is a esophageal high resolution manometry that we do at our center, where we can see that this is the esophageal swallow. There you can see the upper yellow line is the upper esophageal sphincter. The lower green line is the lower esophageal sphincter. In between is the esophageal body, from where the swallowing starts when there is a high pressure zone, because here the color indicates the pressure. The red color indicates the higher pressure, and the yellow and the green and the blue indicates significantly lower pressure. So as the bolus goes down, the pressure is high in the esophagus, and then there is a relaxation of the lower esophageal sphincter when the bolus comes in the lower esophagus. You can see here that there is a relaxation. The pressure difference from green, it turns blue. So the lower esophageal sphincter is relaxing, and then the bolus passes into the stomach. And here the time taken. So this is the deglutative window when the swallowing starts and swallowing ends. And that is the wave of the esophageal peristaltic wave and the lower esophageal sphincter. So here also one can measure the hiatus hernia distance and can identify whether there is any hiatus hernia or not. The indications for manometry: persistence of symptoms, recurrence of symptoms, investigations for atypical symptoms, confirmation of diagnosis, and all patients prior to laparoscopic fundoplication will do a manometry. Now, esophageal manometry may be normal, or it could be failed peristalsis, it could be reduced amplitude, lack of LES relaxation, which happens in several other diseases, motility disorders, and sometimes there can be high increased amplitude, lack of relaxation, and this outlet tract obstruction. So manometry today is classified, it is documented, and it is reported according to the Chicago classification, where it measures the IRP, the upper, and then based on this, we divide whether it is achalasia type 1, type 2, type 3. If IRP is more than upper limit of normal and it is not achalasia, then this could be an EGJ outflow obstruction. If IRP is normal, and it could be a diffuse esophageal spasm. So these are two other major disorders of esophageal peristalsis. Apart from achalasia cardia, there could be EGJ outflow obstruction or diffuse esophageal spasm. But in normal patients or in GERD patients, the kind of esophageal disturbances that we see are called ineffective esophageal motility, IEM, fragmented peristalsis. And this are the findings on manometry, which will tell us whether these patients have these minor disorders of peristalsis. If they have this kind of disorders, then we will do a tope fundoplication. If the esophageal peristalsis is normal, that means more than IRP is normal and more than 50% effective swallows, then we will go ahead and do a Nissen fundoplication. An ambulatory 24-hour pH monitoring is a very sensitive test to detect GERD, and it quantifies reflux disease, and the acid reducing medications have to be discontinued for at least 7 days because the PPI pumps, proton pumps are active till 7 days. If endoscopically confirmed esophagitis is there, there is no need for pH monitoring for diagnosis or prior to surgery. So for erosive GERD, we don't do the ambulatory 24-hour pH monitoring at our center. We do it only for undiagnosed patients, atypical symptoms, and for patients who are volume refluxers. The Demister score is the most important score. More than 14 is considered abnormal, and it is considered to be GERD. But if you do only 24-hour pH monitoring, then it can miss the biliary or the volume reflux. So for these patients, impedance monitoring is necessary. Radiography, we already seen. Chest X-ray can be useful only for large hiatus hernia. You can see here there is a big air fluid level in the lower esophagus, suggestive of hiatus hernia with a contrast study. Upper GI series, you can see here that they evaluate the anatomy. They have an important role in patients follow-up who already have had a fundoplication, but now they have symptoms. Upper GI series is very important, and it will also help us to know whether surgically our wrap is proper or not, detect post-operative complications after fundoplication. So upper GI series is not a test which we do for primary GERD, but if patients have recurrent problems after doing a fundoplication, then barium is definitely necessary. In uncomplicated GERD, hiatus hernia, CT scan or barium is not needed. But for complicated patients, large hernias, those who have complex hernias like paraesophageal type, rolling types, those who have recurrent symptoms after fundoplication, definitely we need to do a CT scan and identify what are the problems, what is going on. The barium study also will identify structural abnormalities of esophagus, like shortened esophagus. When there is a very large hiatus hernia, we should do a barium test. But early esophagitis and other things are not well documented on barium. But it is a good test to detect post-operative complications after fundoplication. You can see here, there is a large sliding hernia half of the stomach is up in the chest. These are all the images where after fundoplication, there are problems, complications, inadequate wrap. This is a slip wrap. This is a herniation of the wrap into the chest. So all these complications can be detected on barium studies. Now let's come to the surgical steps, which are important. We will talk about some of the surgical or technical steps. Before we go to the video, careful positioning of the patient on the operating table to avoid injuries. Under general anesthesia, safe entry into the abdomen for any laparoscopic surgery. The telescope should be placed slightly higher up from the umbilicus, at least 5 centimeters above the umbilicus, depending on the build of the patient. If the patient is thin and lean built, 5 centimeters is good enough. If the patient is very obese, has a very wide subcostal margin, has a central obesity, then we may have to go even 7-8 centimeters above the umbilicus, depending on the body habitus. So this entry, the telescope, is very important to get a good view of the G junction. We need to place the telescope slightly higher up, and we need to use at least a 30-degree telescope for proper vision around the G junction. So that is the first important thing. The standard technique is using 5 ports, and we need 2 operating ports and 2 assistant ports. The 2 assistant ports, one is the epigastric port for the liver retraction. If the liver is very fatty, we can use several ways like blunt rod, or we can use a Nathanson retractor or blunt rods. For the stomach traction, the left-sided flank port is used, and generally we can use either a bowel grasper or an endoclinch type of a grasper to retract the stomach. And the 2 surgical ports are in the right and the left abdomen. Dissection around the G junction is the primary step and the most important step for adequate inspection of the G junction and adequate mobilization of the intra-abdominal esophagus, and reduction of the hiatus hernia by dissecting into the mediastinum, into the lower mediastinum, and dissecting the hiatus hernia. So this is a very, very important step, and for this it is preferable to use some good energy source. One can do it without an energy source. We can do it with a monopolar and a combination of bipolar, but it will be helpful to use a harmonic or an ultrasonic scalpel at this point to do a proper adequate dissection. We'll come to the video and I'll show you the steps of the video. After this dissection is done, the next step is to mobilize the fundus by dividing the short gastric vessels. We have to identify the anterior and the posterior vagus nerves and protect both these nerves from injury, because otherwise these patients will have post-operative distension, dyspepsia, bloating, and other problems if the vagus is injured. Especially the vagus may be injured while doing the esophageal dissection or by doing the fundoplication, taking the sutures near the esophagus. So at both these areas, times we have to be cautious not to injure the anterior as well as the posterior vagus nerve. It's a good idea to keep them in view and to avoid injury to these nerves. And then the crural repair, the approximation of the right and the left crus of the diaphragm with non-absorbable sutures. Preferably we use mattress sutures in most patients to do this repair, and it should be a lax repair, not a very tight repair. Normally about 2 or at the most 3 sutures are needed to repair the crus. And then we create a short and a floppy tension-free fundoplication around the distal esophagus, which is anchored to the esophagus, and the entire wrap is also anchored to the crus of the diaphragm to prevent reflux or migration of the wrap. So how do we assist or make sure that this is a floppy? We will come to the video and show. So this is a Nissen fundoplication. We have to create a lower esophagus, and it is very important to create the wrap around the lower esophagus, not around the stomach, and make sure that we fix the wrap to the esophagus. Otherwise the wrap can slip from the esophagus into the stomach, and if it slips onto the stomach, then these patients will have problems. They will have dysphagia, they may have post-operative regurgitation and symptoms, new onset of symptoms. And that's why it is very important to take each and every step in great importance. This is the Tope fundoplication. It is a partial wrap, which is the posterior wrap. It is a 270° or even sometimes 180°, but generally 270° tope posterior wrap. And we need to take sutures on both the sides to create this kind of a wrap, what is also called as a tope fundoplication. Now, whether to do the Nissen or a tope fundoplication is a question. Both of them are very effective operations. Both of them have almost an equal success rates. Maybe Nissen may be slightly better than tope in terms of efficacy, but otherwise tope is also quite an effective operation and gives very good symptoms and patient satisfaction in almost 90% of patients if done for the right selected patient and if done by the correct technique. Then almost 90% of patients will have an excellent control of the reflux. Symptom control also is very good with Nissen and tope. But the difference is in the postoperative dysphagia rates. Postoperative dysphagia rates I reported higher with Nissen fundoplication than with the tope fundoplication. And operating times are slightly more with the tope fundoplication because you need more number of sutures in a tope fundoplication than in a Nissen fundoplication. But perioperative complications are almost the same. There is no risk increase, does not increase the risk. And for moderate to severe GERD, Nissen is a good option. Tope may not be such a good option because the efficacy is slightly lower than Nissen. So if there is severe GERD, large hiatus hernia, then it is better to use a Nissen operation, but provided the esophageal motility is normal as determined by manometry. Elderly patients, those who are likely to have motility problems, likely to have dysphagia, those patients who have likely to have dysphagia after surgery in the term of they have a peptic stricture or they have underlying motility problem, then it's better to use a tope fundoplication and avoid a Nissen fundoplication. And patients in whom manometry shows that the esophageal peristalsis is ineffective, it is disturbed, it is reduced, then it is better to use a tope fundoplication, a partial fundoplication, and not a Nissen. So with this in view, if this we keep very clear, then we can reduce or at least as far as minimize the risk of post-fundoplication problems, complications, and symptoms. Because these patients have a very difficult problem. This will actually, it will not only harass the patient, but even the surgeon will be harassed because this patient will keep coming again and again with symptoms after a fundoplication, and that's what we should try and avoid as much as possible. The prevention is 1,000 times better than cure. Postoperative care, we don't use routinely nasogastric tubes. One can use it for 12 hours or at the most 24 hours after the surgery. Antiemetic medications are necessary to reduce the risk of postoperative nausea, vomiting, which can have an impact on the repair. Clear liquids are started about 12 hours after the surgery. Barium swallow can be done to assess, but we don't do it routinely in our patients. Only if they have any dysphagia or symptoms, we do a barium swallow to know the emptying, which is also called a timed barium swallow. The postoperative outcome is classified as complete response where patients have no residual symptoms, partial response if they have a mild residual symptoms, appearance of new symptoms, and absence of clinical response. Post-fundoplication complications can be failed wrap. The symptoms persist. It could be dysfunction, symptoms reappear, or it could be complications where there are worsening or development of new symptoms. This is a post-fundoplication narrowing because of several reasons. This can be too tight a wrap, too long a wrap, too narrow a wrap, a lot of fibrosis. Sometimes use a mesh and mesh causes fibrosis. So all these problems can happen. So for post-fundoplication dysphagia, what should we do? So post-fundoplication dysphagia, if the patient develops, we should do a esophagogram. See, also look at the manometry and see if the patient have any motility disorder reported. Esophagogram will show us whether there is a lax fundoplication or a tight wrap or a migrated wrap or any of these complications. Then we'll have to treat accordingly. Because if there is a normal, then we have to think of a motility disorder, use prokinetics. Sometimes if there is a lower esophageal sphincter is a problem, we can do an endoscopy and see, and we can use a endoscopic balloon. Sometimes if there is a tight wrap, but if they don't respond, then these patients will require a redo surgery. A high resolution manometry will be very important to know underlying motility disorders. So this is a supradiaphragmatic wrap migration. You can see here that the wrap has migrated up into the chest. Post-fundoplication complications, we have to define whether they are esophageal or gastric. If they are esophageal, whether they are related to recurrent reflux or dysphagia. If fundoplication is normal, then we have to look for other causes of dysphagia and delayed emptying motility disorders. If the fundoplication is abnormal, either it is tight, torsion, or lax, then we have to correct them accordingly. And many of these patients will need a redo fundoplication. Causes of failure of the wrap, which have been well described in the literature, are wrap disruption. Wrap gets disrupted, there is a recurrent reflux. Too tight wrap can be prevented by taking less number of sutures and adequate dissection. Some technical parts which I'll show you during the video. This is a slipped wrap. The wrap gets slipped onto the stomach, and this is the wrap which is around the fundus instead of on the esophagus, and gastric denervation because of vagotomy. So all these will carry a lot of problems in the post-operative period. So with the failure and how to prevent them, wrap disruption, we can use absorbable sutures and make sure that the wrap does not get disrupted. We should use non-absorbable sutures. We should avoid absorbable sutures. Too tight or too long a wrap should be avoided. And there are several ways. We'll come to that during the video. Slip wrap, esophageal shortening, inadequate mobilization, and vagus nerve should be protected, and patient selection should be good. So for a safe laparoscopic fundoplication, three things are important. The first and the foremost is the careful selection of the patient. This is very, very important. As we have discussed, only patients who have typical GERD symptoms should be considered for fundoplication. Patients who have regurgitant GERD are good candidates for surgery. Erosive GERDs who have good response to PPI are good candidates for surgery. Patients who have esophageal syndromes are good candidates for surgery. Patients who have extraesophageal symptoms, we should evaluate whether they are definitely correlated with GERD or not. Patients who have hiatus hernia and classical reflux are good candidates for surgery. But if patients have any psychosomatic problems, psychosomatic illnesses, they have to be evaluated. They are not good candidates for surgery. Patients who have severe complications of GERD, they are very good candidates for surgery. They will respond very well to surgery. And patients who have well-controlled GERD on PPI, responding well, mild symptoms, they should not be considered for surgery. They should be considered only for PPI therapy. But we should avoid prolonged acid suppression. We can give intermittent acid suppression whenever needed, rather than using prolonged acid suppression. Meticulous surgical technique is the second part, and which is also very, very important part of fundoplication, because that will prevent many of the complications, because many of the complications that occur after fundoplication are technical in origin. If we don't take care of the surgical technique, we choose the wrong operation. Instead of tope, we do a Nissen, and then we land up in the post-operative dysphagia. So, or we do a Nissen with a tight wrap, or we don't fix the wrap properly, there is a slippage or migration of the wrap. So these are all the complications that we should avoid. Sound understanding of the principles of anti-reflux surgery, and we must be having the ability to manage post-fundoplication symptoms and complications. If we do the operation, sometimes we will have a patient who comes back with absence of, benefit from the operation, or he comes back with a new onset symptoms, or he comes back with recurrent symptoms, or has dysphagia. And we should know how to manage these patients also when we do this operation. So now let's come to the surgical part, the videos part. Okay, so I'm starting the Nissen fundoplication. Are you able to see?
Not yet, sir.
Video?
Sir, first close this presentation, sir.
Okay.
Then, sir, please again share.
Okay. Now, are you able to see the video?
Sir,
Not yet, sir.
Not yet?
Not yet, sir.
Now?
Yes, sir. It started, sir. But start from beginning, sir, because it seems that your topic has not yet come, sir.
Okay. Now, can you see?
Yes, sir. We are.
Okay, fine. So these are the port placements for fundoplication. As you can see, the camera is higher up, at least 5 centimeters above the umbilicus. These are the two right and the left working ports of the surgeon. The surgeon is standing in between the two legs. So it is a leg apart position, as we call it. Both the hands are by the side of the patient, so that the assistants and the cameraman can freely work on both the sides. And this flank port in the left side is the gastric retraction port, and the 5 mm epigastric port is the liver retraction port. So this is the classical 5-port placement of the, for the trocar position. The OR setup, as you can see, surgeon is in between the legs. The assistant surgeon is standing to the right side. The camera surgeon is standing on the left side of the surgeon. So this is how is the nurse will be standing here to give all the instruments to the patient. All the wires will be coming here. The monitor will be on the head and side of the patient in the front of the surgeon. A second monitor for the camera person or the assistant surgeon can be adjusted on each side. So you can see here as we go in, the liver is retracted first. You can see here it's the blunt rod that retracts the liver. And we are just assessing the hiatal hernia. Now the dissection is starting. The first step is to enter the lesser sac through the gastrohepatic omentum. So the lesser omentum or the gastrohepatic omentum is divided. We generally use a harmonic scalpel to divide and enter into the lesser sac. So that is the first step. Next, we go towards the esophagus, but here we have to be careful about the pharyngoesophageal membrane, but we have to be careful about the left or the anomalous left hepatic artery. Next step is to do the dissection around the G junction. You can see here we are doing dissection on the left side of the G junction to create that area, identify the left crus and the right crus obtain. So here you can see that we are now coming back to the right crus, and we are now going behind the esophagus, dividing the crura near the right crus, dividing the peritoneum rather. So here we will see mobilize the esophagus, the lower esophagus, and you can see the lower esophagus in view here. The pharyngoesophageal membrane is being divided. The right crus is also seen, and this pharyngoesophageal membrane is divided anteriorly also. We should remain away from the esophagus to prevent injury to the vagus here, because anterior vagus is closely associated with the esophagus. So once the lower esophagus is completely mobilized, we pass umbilical tape behind the esophagus and we tie this tape, so that will help in the traction of the G junction when we do the mediastinal dissection and during the fundoplication. The next step is to mobilize the fundus of the stomach. You can see here how the fundus is grasped and the fundus mobilization is started. Again, the surgeon uses the harmonic and remains close to the stomach as we go and take the short gastric vessels close to the stomach, and then we go into the I just need to recharge my laptop, just a second. Okay. Okay, so now we can see here, just a moment, I'll just okay, so that is the fundal mobilization continuing, short gastrics, the topmost short gastrics, some mobilization of the posterior wall of the stomach, posterior gastric veins also is necessary to reach up to the G junction. From behind, we will see the crus and will remain close to the stomach and the esophagus while doing this dissection. Now, the next step is to identify, do the mediastinal dissection, and then the crural repair starts. After the mediastinal dissection is done, you can see here that the approximation of the crura, and we take a mattress suture so that it will not slip or it will not cut through, because crura is one structure where there is a lot of stress, especially when the patient coughs or sneezes. There's a lot of stress on the crura. There are some people who use pledgets on the sutures. We don't use pledgets. That is not necessary, but it's good idea to have a to have a mattress sutures on the crura. So generally 2 or at the most 3 sutures are necessary depending on how wide is the crural defect. But we should make sure that the crura is slightly lax, because that will allow the esophagus to expand or distend when the esophagus bolus goes down or swallowing happens. So this dissection, if this is very tight closure, then this can cause dysphagia. We should keep some distance so that the crura is not very tightly approximated. That is very important. The next step is to do the wrap, go around behind the stomach. This is the closure of the stomach which is done. There was a serosal tear. Now you can see that there is a shoe shine maneuver. The fundus of the stomach is taken from behind. It should be very, very lax. And this 360-degree wrap, and the sutures should be taken at the apex of the wrap so that it is a lax fundoplication. The umbilical tape here helps in the retraction so that the wrap happens on the esophagus, not on the stomach. You have to pull the esophagus G junction down, and you can see here that it is on the lower esophagus, the wrap, and it should be at the apex of the crura so that it is lax. It is not very tight. You can see here it's a very short and a very floppy fundoplication so that it is not tight. One can use a bougie inside the esophagus. A bougie inside the esophagus, at least a 35 or a 40 French bougie inside the esophagus, can also be used initially when one is in the learning curve. But as one becomes more experienced, one can avoid this. So you can see here that only 2 sutures are taken. It's a short floppy fundoplication, and this wrap is then fixed to the right crust of the diaphragm with 2 sutures, because this will prevent the migration of the entire wrap to the esophageal hiatus. That can be a complication. And that's why it is important to fix the wrap to the crust of the diaphragm by at least 2 sutures so that this wrap does not migrate into the lower chest. So with this is the end of the procedure. It's a very standard procedure. On an average, it takes about 45 minutes to 1 hour to do the entire procedure if everything goes smooth and you have a good team. Next, I would like to show you a tope fundoplication.
Sir, can I, sir?
Yes, please.
Sir, my video is going in the form of pictures, sir, not in a smooth video way, sir.
I think it's very related to the speed of the internet.
Yes, sir. So can I, sir, share it from my side, sir? Because you have already sent it to me.
Yeah,
sir.
sure. Please do that.
Okay,
Please
sir.
share it and show the second. So you want to repeat the first video or you want to show the second video?
Sir, what you say, sir, accordingly will do, sir.
So let us show the first video again then.
Sir, we'll go with the second one, sir.
Okay, fine. So let us go with the second video. It's called the tope fundoplication. It's a short video, 1.5 minutes. But unless you see the first video, it won't be clear because it is in continuation to the first video. So can you please share the first video first?
Okay, sir. Okay, doctor.
Nissen fundoplication, first video.
Sir, have you stopped your sharing, sir?
Yes, yes.
Okay, sir.
Goals that can be achieved in the time frame.
Okay, you can go to the second video then.
No, sir, no issue, sir. Give us a 1 minute, sir.
Fine, fine.
Give us 1 minute, sir.
Okay.
Yes, sir. Sir, has it is
Santosh. Yeah, it can be seen very well, very clearly. That's the hiatus hernia, the dissection of the gastrohepatic ligament, entering into the lesser sac. Make sure that there is no accessory left hepatic artery crossing the gastrohepatic ligament here. As the dissection proceeds towards the esophagus, the anterior lamina of the phrenoesophageal ligament is divided to expose the anterior wall of the esophagus, and then the dissection proceeds to the left of the G junction to dissect around the G junction. The left crus is exposed. Now the right crus is being exposed. The peritoneum over the right crus of the diaphragm is incised. Posterior lamina of the phrenoesophageal ligament is divided. The lower esophagus is dissected. The lower esophagus is mobilized. Anterior mobilization of the phrenoesophageal ligament is done. Anterior vagus is preserved. An umbilical tape is passed into the abdomen, which is taken from behind. It is tied so that can be helped to retract the G junction for the further mobilization. Next step is to do the fundus mobilization. Fundus mobilization is done by dividing the short gastric vessels, remaining very close to the stomach. We do at least a proximal 30%, 1/3 mobilization of the gastric fundus. We take all the short gastrics, remaining close to the stomach. We use a harmonic scalpel. As we go up, we have to be careful regarding the short gastric vessels as we go towards the upper pole of the spleen, because here the short gastrics are very short, and if they slip and bleed, there can be severe bleeding, and that's why it is important to remain remain close to the stomach here. The lower esophagus is again divided. The mediastinal dissection is now started between the two crusts of the diaphragm. The hiatus hernia is reduced by the mediastinal dissection. Posteriorly is done. Now the crural repair is started. Mattress sutures are taken. About 2 or 3 sutures are necessary. The serosal tear on the stomach being repaired, related to the retraction injury on the stomach. The fundus is passed from behind the esophagus. A Shushan maneuver is done, and a lax fundoplication is performed. 360-degree wrap, the Nissen fundoplication, with the apex of the stomach, which is mobilized. Make sure that it is a very lax fundoplication. Here also, Just 2 or 3 sutures are taken, not more than that. One of the sutures passes through the esophagus so that the wrap is fixed onto the lower esophagus. The retraction of the G junction is important to make sure that the wrap is on the lower esophagus. The entire wrap is also fixed to the right crus of the diaphragm. By 2 sutures to prevent migration of the wrap. Okay, fine. So go to the next video, which is a very short video, 2 minutes, and that is the last video now. We are coming to the end of the session. This is called the Tope fundoplication. Yes. So in the Tope fundoplication, the steps are same except for the repair part. The repair which is done is on both sides of the esophagus. You take at least 2 or 3 sutures on each side of the esophagus. While we are taking the sutures, we have to be careful not to injure the vagus nerve. You can see here that the sutures are taken on both sides. Tope is a very good operation. It's quite an effective procedure. One can use it liberally also. And so it's a good operation to learn. One can see that it's a partial wrap. It's a posterior wrap and it is adequately fixed. You need more number of sutures to fix the tope because it is done on both sides of the esophagus. And finally, the wrap is fixed to the crus of the diaphragm to prevent this wrap from migrating. That is the end of the procedure. The umbilical tape is cut and it's the end of the wrap, the end of the procedure. So thank you very much. I'm at the end of the presentation.
Thank you so much, Sanjeev. That was an exhaustive, very well defined actually. Thank you so much. Actually, all the surgeons actually who are viewing this must have been immensely happy because Sanjeev has covered each and every aspect, right from indications to the workup, to the technical details of the operation. I think there are no questions that we need to come from this. We have some questions from some people, Sanjeev.
Yes.
Now, what the Nayak from Kadir wants to know. Now, see, at a periphery center like us, we don't have 24-hour pH metry. And also a similar question from Prasad from Anantapur. He says, is endoscopy and barium okay to do an fundoplication at a peripheral center like us?
I think that's a very practical question. I would say 24-hour pH metry is not a must before all surgeries. So if there is a classical GERD, erosive GERD, it's these patients have classical symptoms, then we can do a fundoplication without doing a 24-hour testing. Manometry is something that is desirable to do before we do a fundoplication because sometimes it will help us to save from a problem, postoperative dysphagia, postoperative complications. So if we can identify some underlying motility disorder of the esophagus, especially failed peristalsis, ineffective motility, or sometimes even some motility disorder like achalasia or EJJ outflow obstruction, then it will help us to prevent a post-operative disaster, because these patients otherwise after the surgery it will be very difficult to manage post-operative fundoplication, post-fundoplication dysphagia. It's very difficult to manage this problem. That's why it is better to prevent it. And the best way to prevent this problem is one, manometry, choosing the right operation, and two, technical aspects, doing a lax and a very lax fundoplication. So this is the only way to prevent this problem. And that's why if you want to prevent, then it is better to do a manometry. You could send a patient for a manometry to a nearby center, get a high resolution manometry done, and the patient can come back and you can do the fundoplication. So that is a option. I think that will be more desirable rather than avoiding a manometry and doing a straight fundoplication, because it's very difficult to manage these patients post-operatively. So it's better to prevent these problems before we land up in these problems.
Yeah, very right. Actually,
what is your opinion?
Yeah, very right, Sanjeev. Actually, see, I think manometry is one test which is very, very important actually. And I personally believe that the incidence of dysphagia following fundoplication is less in the current day series, basically because of the manometry being done, which are picking up the motility disorders, which are also responsible for the post-op dysphagia. So 24-hour pH-metry may not be, but I think manometry is a mandatory thing before you do this procedure. Absolutely right. Now, the second thing that what Dr. Deshmukh from Nasik wants to know is division of short gastric vessels mandatory before you do the fundoplication, both Toupet and also the classical Nissen fundoplication.
Yeah. So if you talk science, it is different, and if you talk practice, it is different. Science, the studies show that even if you divide the short gastrics or don't divide the short gastrics, does not matter in as far as laxity of fundoplication or the results of fundoplication are concerned. But if you see the practice, most of the surgeons, I would say more than 95% of surgeons divide the short gastrics while they do the fundoplication. I always have divided the short gastrics because I believe that if you really want to do a lax fundoplication, then you need to divide the short gastrics. And that's why I have always done that. So far, I have not regretted. I have never not divided a short gastric. So I don't know how lax you can make it without dividing the short gastrics. What is your opinion, Dr. GV?
Yeah, absolutely. You're absolutely right. Actually, I concur with you, Sanjeev. Sanjeev, there's another question from Dr. Amit Acharya. Now, he says, what will you do if you injure vagus during surgery? What are the indications for mesh and what size?
So if you divide the vagus inadvertently and you recognize it during surgery, there is hardly anything you can do. You can't repair the vagus. It does not help. But it is said that at least if you divide just one and if you preserve one vagus, then most likely the patient will not have severe symptoms. So if you have divided one vagus, you must make sure that you have preserved the other vagus. At least that is number one. That is important, because if you denude both the vagi, anterior and posterior, definitely these patients will have gas bloat, ineffective problems related to gastric motility, emptying, and that's why they will have symptoms related to bloating and eructation, belching. So all these symptoms can come up, and sometimes they may also have ineffective gastric motility. So these problems can come up. So that is number one. Number two, mesh is a completely different situation, because mesh is not it is not going to help if you divide the vagus. What mesh is needed is for very large hernias, very large rolling type of hernias, where the defect is so wide that just by primary repair you may not be able to completely take care, or when you are doing a redo fundoplication. So mesh is useful in this scenario. But even after using a mesh, the risk of recurrence of hiatus hernia is quite high in these patients, because in these patients mesh also has a small risk of complications. I also had a short video and a presentation on mesh related complications which we have encountered related to several strictures, scarring, stenosis. So all these complications have been encountered, erosions of the mesh. And that's why we have now used mesh less and less frequently after fundoplication. One reason, because it is not as effective. See, wherever we use mesh, anywhere in hernia, there is one cardinal principle to get at least a 5 centimeter overlap around the hernial defects with a mesh, which is violated in a hiatus hernia. You can never achieve a 5 centimeter coverage because the mesh will just cover your defect. It cannot get a 5 centimeter overlap beyond the defect. And that's why, because we don't believe this principle, we can't follow this principle, the risk of recurrence is very high. And the other reason is that there is a very high transdiaphragmatic pressure gradient. When the patient coughs, sneezes, there is a very high pressure gradient. So the risk of hiatal hernia recurring is quite high in these patients. Recently, we had 2 patients who had cerebral palsy, CP child. We have done fundoplication. In both the patients, they developed recurrences after 5 years. And the second patient, we just recently operated after 7 years. So these patients have a very high intra-abdominal pressure because of the spasticity of cerebral palsy. So they had reflux and hiatus hernia, which was the cause. But this was also the cause of the recurrence. So we have to understand all these, the transdiaphragmatic pressure gradients and all these physiology also we need to understand that why the recurrence happens in these patients. In spite of putting the mesh, these patients may develop a recurrence, and there is a risk of mesh related complications also. So now we are using it less and less sparingly. We used to use this dual layered mesh with a slit in between going around both sides and anteriorly overlapping the mesh anteriorly around the esophagus. That is the technique that we used to use. But now we use the mesh quite sparingly. What is your opinion, Dr. GV?
Yeah, absolutely. The incidence of mesh repair has tremendously come down. What is absolutely right, and concur with you. And there is Dr. Amit and Jitender want to know, what if we accidentally injure the pleura? What do we do in case of left gastric artery injury?
Yes, that's a good question. So pleura, yes, it's a common problem. Not very common, but especially for large hernias, recurrent hernias, it is quite common to open the pleura. And many times we can detect it on the table. We will be able to see whenever there is inflation, we will be able to see the lung, or you will be able to see the pleural cavity. You can detect it on the table. Don't worry at all. Only thing is, tell your anesthetist that the pleura is open, because when the CO2 gets into the pleura, it gets absorbed very fast. The entitled carbon dioxide may go up because of the rapid absorption of carbon dioxide. And sometimes the lung may get collapsed, and that may cause problems with ventilation. So just inform your anesthetist. He may use a slightly higher pressures, airway pressures to ventilate the lung, and that will take care of the problem. Generally, nothing happens during the surgery. Now the question is, at the end of the procedure, whether you want to suture the pleura, close it or not. Most of the times we have not closed it, and it is not necessary to close the pleura also. So you don't need to close the pleura. Now the third question is whether after the surgery we'll put a ICD or not. That is the third question. Now, most of the times it is not necessary to put ICD in all patients. Our own experience suggests that one can wait. We hyperinflate at the end of the procedure. When the carbon dioxide is released from the abdomen, we hyperinflate the lung. The anesthetist is asked to hyperinflate so that all the air evacuates, all the carbon dioxide and the air evacuates from the chest. Post-operatively, immediately on the table, after extubation, we get an X-ray done, and we document how much is the pneumothorax. If the pneumothorax is very mild and patient saturation is normal, we don't even put an ICD tube. We observe these patients. If the pneumothorax is going to go up or they develop any saturation fall, then we will put an ICD tube. That is our protocol of managing these kind of patients. We don't use the routine ICDs nowadays. Also, you used to use routine ICDs, but now we use them more and more sparingly for necessary if only the patient needs it. At the most, we can observe these patients if they have less oxygen saturation, maybe in a ICU for a day, and see if they have developed any problems related to pneumothorax.
The left gastric injury, artery injury, when done?
Yeah. We have not encountered a left gastric artery injury, but we have encountered a left hepatic vein injury. And we have reported this injury about 15 years ago in a hiatal hernia. It was a large hernia, which was, anatomy was quite distorted. We injured a left hepatic vein during a fundoplication, and then we reported this injury. And here it was quite difficult to manage because the hepatic veins, they immediately swell up. So we had to convert to open surgery to mobilize the left lobe of the liver and go to the left hepatic vein and repair the left hepatic. But it was surprising that it was so easy to injure a left hepatic vein during a fundoplication. It wasn't that we were quite away from the G junction. We were working quite close to. We had this video also, which was a very good video. Left gastric artery injury will be quite rare. One has to be careful, of course, but it can happen because you're going onto the lesser curve and you are opening the left gastric ligaments. So the good way is to visualize the left gastric vessels. When you open the lesser sac, the first thing, then you retract the stomach, you will be able to see the left gastric vessels. So make sure that when we open the posterior, the peritoneum on the crura, that we start above the left gastric vessels. We are not below the left gastric vessels so that we don't injure. So prevention, I think, will be the most important. But if it gets injured, definitely, if we can control it laparoscopically, it's nothing like it. We can take it, clip it, or ligate it, or even use a ligature if it is a distal injury near the stomach. But if it is a more proximal injury, then we'll have to clip it or we'll have to ligate it. So if we can do it laparoscopically, yes, fine, or we can open and repair the ligate the left gastric artery. So left gastric artery ligation is fine. The patients don't develop any complications. It can easily be ligated.
Very right. The other, Dr. Vishal from Ajmer wants to know, you've used mattress sutures for on the crura. Is it mandatory that we use mattress or simple sutures are okay?
So many people use simple sutures, but I believe that the chances of cutting through with a mattress suture will be lesser than a simple suture, because simple suture, now you just visualize that this is the diaphragm, and when the patient coughs or sneezes, there will be so much tension on the crural repair, especially when immediately post-operatively patient, while he is coming out of anesthesia, is retching. How much will be the tension on the crural repair? So if it's a simple suture, then it can just cut through. It's a mattress suture, then it can hold better because the mattress configuration is such that it is not at the same plane, it is at two different planes, and that's why the chances of cutting through. This is a theoretically that I feel, and that's why people use pledgets. We don't use pledgets, they're not available. So instead of pledgets, it is just simply, using a mattress suture is a good option. It is not difficult to take. If you are used to taking mattress sutures, then it is not easy. You may not say mattress is slightly difficult laparoscopically because then you have to do reverse suturing. So either you take a reverse suturing with your right hand or you use your left hand. If you are good at both left-handed suturing, you can even use your left hand to do the suturing. But if you want to avoid all these complications, the simplest way is to use a figure of 8 so that the configuration is the same. You go and again you go through the same way. It's a figure of 8 suture rather than a mattress will be a good option. It's very easy to do it laparoscopically, not very difficult. Just requires, some awareness and practice, and you can pick up very easily. Not a problem.
Thank you. And one last question, actually. How do you manage this post-fundoplication dysphagia?
So post-fundoplication dysphagia, the first test we will do is a barium swallow. And barium swallow will tell us whether there is any, it's a timed barium swallow. Timed barium swallow is that you give a semi-solid kind of a barium, semi-liquid or liquid kind of a barium. It's not the regular bolus swallow that we give. It's a liquid swallow, liquid barium. And then we take it when the patient is swallowing at 1 minute, at 2 minutes, and at 5 minutes. And then you measure the height of the column and you see the emptying. Idea is to see how rapidly the emptying is happening from the esophagus into the stomach. So at 1 minute, at 2 minutes, and at 5 minutes, you measure the height of the barium column. You see the width of the esophagus and the height of this column. These are the two things that you see. And then based on this, you identify whether there is a emptying problem or not. So if the emptying is a problem, definitely there is either a tight wrap or there is a motility problem or there is a stricture or something. Some problem is there. Either the crural repair is tight, either your wrap is tight, some or the other problem is definitely there. So now the next phase is to differentiate whether it's a motility problem or it's an extrinsic compression. And to differentiate this, manometry is the best test. If you have done it before surgery, go back to your manometry and see. If you have any doubt, you can repeat the manometry, or if you have not done it before surgery, then you can do a manometry as the first step. And then decide what to do. If there is a tight wrap, if there is an extrinsic compression, it is better to go in early to do a redo procedure and release this repair or release this wrap, remove the sutures. because then the patient will have a rapid control of the dysphagia. If it's a tight trap, it is better to convert to a tope immediately rather than waiting and hoping that it will improve, it will improve. It does not improve. So it's better if on the 4th, 5th day patient does not improve, patient has severe symptoms, it is much better to go back, explain the patient, redo and release the crural repair and convert your Nissen wrap to a tope wrap. That will be much easier to do it immediately post-operatively. What do you think, Dr. GV?
Absolutely. What you said is absolutely right. Actually, these things, mechanical problems, these need to be addressed, Sanjeev. One last question, Sanjeev. Do you routinely roll up PPIs post-fundoplication?
Post-fundoplication, generally PPIs are needed infrequently and for some time. Regular PPI is not necessary. If patient needs regular PPI, it's a failure of the operation. So we need to identify what is the cause. Generally, these patients will not need regular PPIs as they used to need it. Yes, occasionally they have some symptoms and you give a short course, that is fine. So we need to differentiate whether it's a short course PPI or they need a prolonged PPI. And if they need a prolonged PPI, they definitely need the evaluation whether it's an inadequate wrap, it's a lax wrap, if there is a reflux, or there is some failure of fundoplication for any cause because of either slippage or migration of the wrap. So all these need to be evaluated. And if they need short course PPI for some reason, or this could be some other problem, it could be non-ulcer dyspepsia, it could be motility issue, it could be H. pylori, it could be gastritis or an ulcer disease. So we need to evaluate whether these patients have any other problems apart from GERD. And the third issue is the psychosomatic issues. Psychosomatic problems are very, very frequent these days. Almost 75–80% of patients who have GERD have a psychosomatic issue. So we have to be very, very careful before surgery in evaluating these symptoms. And we should also evaluate whether there are any such psychosomatic illnesses for which they need PPI. And sometimes for all patients, motility issues or for dyspepsias, PPIs are not useful. Sometimes only prokinetics are beneficial for this kind of issues, and they may do well with prokinetics alone.
Thank you so much, Sanjeev. That was an exhaustive for you taking your time off. Actually, you cleared most of the doubts. Actually, you may receive some questions directly on your mail, Sanjeev. Actually, we hope that you can answer some of these, and maybe if possible, maybe talk to some of the surgeons who may directly get in touch with you regarding some applications. Thank you so much. Again, on behalf of Sun Pharma and on behalf of myself, my sincere thanks to Dr. Sanjeev for sparing this time. And I do hope people who have viewed this have been immensely benefited by the technical tips that were given. Please feel free to contact us actually anytime through mail or through the Sun Pharma representatives who are meeting you regularly so that they can pass on the questions. We'll certainly be in touch with you regarding the future programs. And I hope you enjoyed viewing this. Thank you so much once again for joining this program. Thank you so much, Sanjeev. Thank you so much.
My pleasure, Dr. GV. Thank you very much for this opportunity. And can I suggest to you and to the Sun Pharma people that such a wonderful initiative that you have taken, why don't you, create a website where all these presentations and videos can be hosted for anyone to access anytime in the future?
Yeah. These are all on YouTube, actually, Sanjeev. Actually, they're all putting up these things on the YouTube. Actually, they'll soon share with you the YouTube link for this presentation.
Wonderful. Thank you so much.
Thank you so much. Thank you so much.
Thank you, doctor. Thank you, sir. Thanks a lot.
Thank you, Vamsi.
Thank you, sir.
Thanks, Santosh.
Thank you. Thank you, doctor.
Thank you, sir. Thanks.
Thank you, sir.
Arvind, you can log off, Arvind.